of you are able to do formal interviewing of children and spend at least an hour talking to at least an hour? Can you spend, and how many of you also can spend an hour speaking to a parent? Okay, well then that's good. I mean, I guess, but how many of you, you're in the schools, how many of you in your clinics can just spend time assessing and diagnosing? Okay, well that's, okay. Because many times people say they got to get right in there and start treating. So I'm happy to know that you can start spending time. Because I would argue, again, the most successful way to treat a child with anxiety problem is to conceptualize the anxiety problem. I wouldn't want to go to a medical doctor if he didn't know what or she didn't know what he was treating. I wouldn't want to go to a specialist without knowing, is this anxiety or depression or ADHD? And I didn't even get into, the differential diagnoses there. I told you about anxiety and depression. Anxiety and ADHD is also highly comorbid. But with ADHD, it's more like the concentration and distraction that you see, and you see that with anxiety as well. But other than that, you don't have the content areas of worry with ADHD kids. If you do, then you have ADHD comorbid with anxiety. Okay? So, the interview, this is an interview schedule that I developed. It's the one that's used in almost all the clinical trials. The 30, 40 studies that have been published, they all use my interview schedule. And there are child versions, parent versions. There's reliability data. It has interference ratings, and it basically yes. This is available through Oxford University Press. Yeah, and the thing about the ADIS is that you don't necessarily have to use the whole thing. You just use it as a template, as a guide. Because unless you memorized DSM and memorized all the differences between the different anxiety problems, it's very hard. I personally think it's really hard. I mean, I can tell now, of course, oh yeah, that child has that. But I've seen thousands. I mean, I've been doing this for over 20 years, I told you, longer than I'm married. So so I've been doing this for a long time. So I can tell really quickly what an anxiety problem is. But if you haven't done it as much, a template, a guide is a good thing. So it contains, and I guess people find it really helpful because, as I said, it's used in all the trials. It contains not just the anxiety, it also contains depression sections, it contains ADHD, it contains conduct problems, it contains screening questions for eating disorders, schizophrenia. It's a full diagnostic interview schedule. And so, for example, I know you can't read this, but it looks like this, where it just asks, some kids worry a lot about being away from their parents or from home. Do you feel really scared or worried that when you go away from your mom or dad and you do whatever you can to be with them? Yes, no. Do you get upset, cry, or beg your parents to stay home when they plan to go somewhere without you? When your parents leave you, do you cry or feel very bad because you miss them a lot? When you know you're going to be away, do you get worried? And if they say yes to any of these, then that's any of these. This is one big spiel in the DSM. And what I did, when I say, you know what a spiel is, right? Okay. What I did is I took the big spiel in the DSM and I broke it up into separate questions, because you can't ask kids a whole spiel. They'll be confused. You have to break it up into small questions. So that's what basically I did. I took the DSM and I just broke it up into specific questions. And so if they say yes to any of these, then that's one. And then here's another one. When you're not with them, do you worry that something bad might happen? Yes. And then yes. And then it tells you if you get 4 of these checked, because if you get a check here, a check there, and then on another page, a check there, if they have 4 checks, then that means they meet this criteria for separation anxiety. So it's a way to facilitate a diagnosis. Now, people have done, many clinicians say, I don't like structured interviews, it's too blah, blah, blah. And I say to you, this is not a structured interview. It's semi-structured. If you're not doing it for research, you can certainly be flexible. In my research clinic, we have to go through everything. but in clinical practice, it's just a template. If you want to write your own questions out along the DSM, then go ahead and develop your own interview schedule. I mean, you don't have to be Einstein to do this, but it was a practical thing to get this done. People have done research questions, and they've asked parents and children, do you mind these interview schedules? And the research is over like 80%, 90% say, no, I like it, I like it. And my experience is, and I've been doing, is when parents come in and you ask them these questions, you know what they usually say? Can you say it?
Nobody's ever asked me before.
Nobody's ever asked me so carefully all these questions. I'm so glad you're asking me these questions so carefully. I can't believe this is exactly my child. Oh, did you see my child when you wrote these questions? And nothing I'm saying to you is a lie or an exaggeration. Believe me, I'm telling you this from my heart. This is the common reaction. Now, of course, I run an anxiety clinic, so the people who are coming to me, of course, have anxiety already. It's a self-selected group of people. We screen them on the phone before they come to us. So, of course, it's not a representative sample. But for kids with anxiety, it's hitting the nail on the head. And they're and I think the children feel the same way. And the reason why they feel this way is, unfortunately, so many of the people have been elsewhere. And unfortunately, I know not to any of you, not to any of you, but they've been elsewhere and they've been told, oh, my child has depression. And I ask, well, who told you your child has depression? Oh, the pediatrician or the something. And I said, well, how did they determine that? And they go, oh, well, they talked to my child. How long did they talk to my child? Oh, like maybe 10 minutes. You said 5 minutes. And I really don't mean to be critical of the care, but people sometimes, I think, just skip things, and I think they don't realize how important it is to spend the time asking these questions. When people use the ADIS and they meet the criteria, then you get an interference rating of 0 to 8 using that scale I showed you, okay? In all the treatment studies where they use it, to get included in the study, it's not just enough to meet all 4 symptoms, you also have to have interference. Because you can have symptoms without interference. Remember, I showed you that. So it's meeting symptoms and having interference. On the 0 to 8 scale, it's 4 or more. 4, 5, 6, 7, 8. Because 4 is considered moderate interference. So if you get a rating of 4, it's considered a specific phobia, but it's not medium interference versus an 8. If you said, I take a train to go somewhere, I will never ever, then it would be an 8 because it's clearly impairing you from that. So that's important to get that rating because it's the 4 to 8, and that's where explaining the rating scale is important. The social phobia asks. The social phobia question, first it asks, there's an introduction, but then it says first it asks about social evaluation. When you're in certain places with other people, like school, restaurants, do you feel that people might think that something you do is stupid or dumb? Yes or no? When you're in certain places, do you think people will laugh at you? When you're in these situations, do you worry you might do something that will make you feel ashamed or embarrassed? If they say yes to any of these, then it's a check. But then what's nice about it is, it then has a list of all the things, answering questions in class, giving a report or reading in front of the class, asking the teacher a question, taking tests, writing on the chalkboard, and then it asks you to rate fear, yes or no, and then to get a rating, And again, you don't have to do all of this, but it has it all in there. But this is the thing I wanted to say, like the specific phobia also has a list of all the things. And you know how many people say yes to like a million things? A lot. Because roaches, insects. So what do you need to say to people to make sure you got it right? What do you need to say to them?
Make sure it's severe enough.
You need to say, well, a lot of people don't like roaches, and a lot of people don't like lizards, and a lot of people don't like snakes. we're talking about things that are so intense that you avoid and stay away. It's not just something that you don't like. And that's part of what you need to ask people about phobias. Like, well, you could have it, but is it interfering? So a lot of the kids say, well, I'm really afraid of flying. But if they're 8 years old and there's no plans for them to fly, it's not interfering yet. Now, many times we get parents who bring their kids to us because the kids have phobias of shots and injections. And they're really worried that they've finished all their shots, but they're worried that when they need to get their next set of shots before college, they're not going to be able to go to college. So I'm not joking, it's true. And so we've treated many kids because they want to do sort of a preparation before they go to college, because otherwise they're not going to take the shots to go to college. Yeah.
Is the internal state of discomfort considered interfering?
Yes. She asked, is the internal state. So interference can be family, it could be friends, it could be school, and it could be internal distress. Internal distress is part of it. And you need to ask the child, so how does it mess things up with family? How does it mess things up with friends, school? And how does it make you feel? Does it make you feel, how much does it bother you? And a lot of times the kids say, it doesn't bother me. I mean, no, but sometimes it does. Or the parents say, and you do need to talk to both children and parents. Why? Because the correlation between what they have to say is like maybe anywhere from 0.4 to 0.6, sometimes lower. They don't always agree. And you need to talk to both of them. And what do you guys do when you have discrepant information? I usually bring them back in, and I try to then figure out which, what, and I try to get, the best thing is to get examples, from both of them, to try to see who has the most evidence. You tell me this, well, tell me more, give me some examples. The mom, tell me more, give me some examples. And, and then I usually bring them in and I reconcile what they tell me. Okay, are there any questions so far about, okay, all right, you're asking, anything else? Now, if you don't have time to do an interview, these are the most common screening measures. And in that, these are the ones that map on to the DSM. If you give this to a child, and there's also a parent version, and if you score it, you will be able to get a score. But what does a screen mean? What does it mean to screen? But it's not a diagnosis, it's a screen. It's just suggesting. It's just, you do not, you cannot give diagnoses or make firm conclusions based on a screen. It just suggests something. But then you might want to follow up with the interview schedule or with your own interview. Now, I put up this one because it's free, and you can download it. Susan Spence is a researcher in Australia. You can go to her website, and it's used a lot, especially in all the Australian research studies of child anxiety. It's got 38 items. There's a child version. I think there's an adolescent version, but I might be wrong. Maybe it's still all together. And then there's a parent version, and that's how the responses are scored. Never, sometimes, often, always. And what's nice about it is, I just want to show you this. You can download this. Is that it then you can't read this, but after you score it, you score it like the kids rate it, then you add up. But then what happens is, you can't read this, but these lines are mapping onto items for OCD. These are the items on the scale that map onto OCD. These are the items on the scale that you score, so you get a subscore, that map onto social. This is the items on the scale that you score to get a subscore, to give you panic, agoraphobia. The same for separation anxiety. Physical injury or fears, which would be specific phobia. And this would be generalized anxiety. And I'm sorry, I can't read the words, but it's very much mapping onto DSM. And then what's nice about it is that you score it, and if you're above This, you're in the clinical, you're scoring the way clinical samples score. And if you score here, you're in between. You're like what's called sub-threshold, subclinical. And if you're here, if you're low, then you're not in the clinical score. Now again, and you have again, it's sort of like an MMPI type of thing. You can get a profile and you can score it like that. Again, it's a screen. I believe you would be incompetent if you ever put on a report a diagnosis using the Spence. But certainly, it's a screen, and then you follow up. And, and it's a really nice, easy way of trying to get a handle on things. The parent score doesn't have the T-scores, but you can get the norms from the website, but it doesn't give you like the cutoffs for the parents. It only gives you the cutoffs for the child version. The research hasn't been done to give you the cutoffs. But at least you get the norms, but you don't have the cutoffs. Yeah. I'm looking for my thing. Yeah. Oh, here it is. Okay. Yeah. Yeah. I feel like Phil Donahue. Remember him? Okay.
You're prettier. Are there reliability studies for
there's reliability.
the ADIS or for?
There's reliability and validity on everything I've told you about. I wouldn't tell you anything if it didn't have reliability and validity, because this is all about evidence-based stuff. This is the website. So if you go to that website, that's how you get the scale. So that's why I told you about that one, because the other scales, you have to pay money. And even my interview, it costs. But the Spence is a free interview schedule, is a free questionnaire. Okay, and then the other thing that is common, I just want to make the point, especially in research, and this is again something you need to buy. That's the Achenbach behavior checklists, which are very common to use, and especially the CBCL, internalizing, or the subscales of anxiety. And again, there's reliability and validity. And just like the Spence, the Achenbach has this exact same idea. You score it, and then you could be below clinical, subclinical, or clinical. And again, those are nice screens. And the reason why I mention this is because the Spence doesn't have cutoffs for the parents. This has cutoffs for the parents. So if you really want to try to get some cutoffs from parent ratings, you need to use the CBCLs and not the Spence. Yes? Oh, can you say it again?
Wondering, because you put the CBCL up here, but it conflates the anxiety and depression scale, whereas the BASC will tease it apart. So your thoughts on that in terms of?
I just have never used the BASC. The BASC is another behavior assessment scale for children. Or do you guys use this a lot? Oh, really?
Because it separates out the anxiety and depression.
Yeah, well, but there is an anxiety-specific scale on the
I've never used that one.
Yeah. So I guess in research, the researchers use the CBCL more, so I'm more familiar with the CBCL. So I can't. Okay, and then the teacher ratings. Does the BASC have teacher form? Yeah. Okay, well, then use that. I mean, if you like it, then use it. I mean, I'm just using the one, telling you about the ones I'm more familiar with, and that's used more in the literature. Okay, and they also have the same subscales. And I didn't put the reference up, but this is Achenbach, ACHENBACH. If any of you really want to explore the rating scales, widely used. Okay. All right. So, I'm actually where I want to be. I went over the disorders. I gave you some background on prevalence and briefly about assessments. Is there any questions about that? Yes.
Speaking to the importance of asking a lot of questions, one of the things I've noticed is people with anxiety often don't report things. You can ask a general question, do you worry a lot? And they'll deny it, but you sometimes need to ask a very specific question, otherwise you never get at really what's going on for them.
Yeah, no, did everybody hear that? Yeah, and that's why I like my interview schedule, because it's very, very, very specific. Exactly. And I also find with anxious children that they like the structure. You know, if you, I mean, it's good to begin with, so what brings you here today? That's a good way to begin. But usually the anxious kids are anxious, and they don't really want to, they're not necessarily, you know, they're inhibited. And it's, you know, sometimes they talk, don't get me wrong, I'm not want to generalize, but for those kids who are the more inhibited type, you know, asking in this type of structured way, and by the way, I feel this way about the treatment. I feel the structure of the treatment is also something that makes them feel safer than a very unstructured assessment approach. I mean, can you imagine giving, you know, the Rorschach is meant to elicit anxiety. And that's what it's meant to do. But I prefer the more structured approach to assessment and you know, somewhat to treatment as well with anxious kids. I think they respond, you know, it hooks them in a little bit easier. This is an important topic, and we'll spend maybe about 30 minutes on it. I don't even think more than that. I just want to 15, 20, 30 minutes. This is an important topic, though, because even someone during lunch said to me that she went to a doctor, and the doctor, when she talked with the doctor about her child, the doctor said, well, aren't you too hard on your child? You know, and so even health professionals sometimes don't know what's behind these anxiety problems and how they develop and what maintains them. And I think it's really important whenever you treat anything to know about the problem and to be able to speak to families and children about it, because they usually ask during the intake, you know, why is my child like this? You know, was it my fault? I remember when I left, my child got lost in the shopping mall when she was 3. She's never been the same since then. Or my mother died and it was very stressful for me, and I'm certain that it was my stress that made my child like this. Or my husband and I got divorced, and I'm thinking that's why it's like that. So these are the constant questions. These are generally the hypothesized risk factors. You know, I say hypothesized because, you know, they're hypotheses. There are theories behind them. And generally what everybody says is that it's not one thing, it's multi-determined. So whenever a parent says, is it because of X, is it because of Y, the answer is, well, you know, it's like a heart attack. You know, it's usually not one thing that gives you a heart attack. It's a lot of risk factors. So these are the risk factors that have been shown through research to be contributing to the development of phobias and anxiety problems. Genetics, temperament, learning, cognitive influences, parent influences, and quote, neural circuitry. And it's complicated, the genetics, clearly heritable, but the precise amount depends on numerous factors, including the type of anxiety, the age and sex of the population in terms of boys and girls, children, teenagers, adults, and what type of method you use to assess the anxiety, you know, in terms of rating scales or interviews, and whether you consider anxiety as a personality trait, because a lot of people view it more as a disposing kind of quality versus a DSM disorder. So that's the bottom line. I mean, I don't really want to get more, you know, it's really more complicated. If you email me, I'm happy to send you the 30-page chapter if you can get the details. But, you know, but that's the bottom line, that yes, it's clear that anxiety runs in families. I mean, it's clear. But you can't say it's all the time, and it depends on different things, and certain problems tend to be more than others, etc. But certainly when we have kids coming through our clinic, I always have them look at the pathology, the history of the parents to get a handle on that. Temperament, again, has been implicated. There's a famous child psychologist at Harvard University. His name is Jerry Kagan, and he's done a lot of research on this temperament quality called behavioral inhibition. In fact, he made a year ago, there was a cover story on the Sunday Times magazine section called Anxiety, and it was all covering his research. So if you Google the Sunday Times magazine, you can find, you know, a nice popular article on his work. And basically what he has found is, and again, those of you who have had children, you know what I never knew what temperament meant until I had my kids. I go, oh, there's no temperament. Oh yeah, there's temperament. I mean, you were telling me about your 2 kids, and and the differences in the temperament of your 2 kids, and so it's something that the kids just kind of like are born with, and it's probably partly a genetic thing that gets transmitted, and it's observable as early as young children, 1, 2, 3 years old, and the one that's linked to anxiety, and particularly social anxiety, but all the anxiety, but particularly social, is behavioral inhibition. So these are little 1, 2-year-olds, 3-year-olds who, when in a new situation, don't want to be in that situation. When these are the little kids who, when you have to drop them off, maybe, at the early preschool setting, don't want to go. Those are the kids who are going to cry when seeing strangers. Those are the kids who are going to cry when the big circus clown comes to them. Those are the kids who are going to cry when they're asked to, go up on some swing and they don't want to go on the swing. The genius about Kagan's work is that he has developed reliable and valid ways of measuring these things through behavior observations, through heart rate monitoring, and he's really documented it. And what's most amazing, and that's why it was in the New York Times, is that he's followed these kids for over 20 years now, and he has now shown how these kids, the most extreme kids, okay, not everybody, but the kids who are most extreme on behavioral inhibition were the ones who ended up with diagnoses of anxiety and social, and not other psychiatric disorders, more specific to social anxiety. So it's clearly a risk factor. And just one more point that's interesting is in Australia, there's been some research now doing early prevention with children, toddler age and preschools, and doing early prevention and teaching parents how to, maybe not, to get their kids to be a little bit less inhibited. And, it's work in progress, but it's now being used as a marker to develop prevention programs, target this risk factor.
I just had a quick question. Clearly, nurture is something that affects it as opposed to nature. But if we're going to say that nature is a key component, does birth order have anything to do with it?
Birth order has never been found. I mean, I know we all, the famous expression among my friends is, if I had my second one first, I wouldn't have had my second. I get one. but it's not true, of course. But that's the joke that people make. So people feel this way, but as far as I know, I'm not really up in the birth order literature. Maybe somebody knows more than me, but I haven't, at least in anxiety, it hasn't been found to be something specific. Okay, learning. Right? So we all know about learning, and we all know. And I wanted to do this, but then I thought there might be some copyright restrictions. My understanding is that you can actually go to YouTube and you can actually get James Watson. He's the famous guy with little Albert, and he was the one that shocked little Albert to become afraid of a white rat. And you can actually see those experiments. I mean, they're awesome. I mean, they're amazing. I recommend you, when after you watch The Office on YouTube, you then go to Little Albert, and you could rent it. But we all know this idea that if something can be paired, and you can then condition to being, if something is associated with something, if you have a rat, and if you get shock to it, then you'd be fearful of the rat, and through conditioning. And there is some, and so that's one idea. The other thing is operant condition, reinforcement, and certainly, and I'm going to talk more about this when we talk about exposure, certainly there's a reinforcement component to everything, and if we stay, and that we can develop and maintain our anxiety by reinforcement. But I'm going to talk more soon about that. Vicarious conditioning, which just means modeling, and they've been doing research with monkeys on this, which is, even monkeys, if they watch something bad happening to another monkey, they can show fearful, anxious behaviors. So modeling and watching people, also being told. So these are all the learning ways. So we can have a direct experience through conditioning, we can be reinforced, we can observe, or we can just hear something. And that's a way that we can develop fears and anxiety. Tom Ollendick, did this study, which I think was always kind of interesting because he looked at how kids who reported, these were more fears, not anxiety disorders, but he looked at kids who reported a lot of fears to these things, not able to breathe, hit by a car, fires, and what you can see is actually, and I always find this interesting. See, I always find this the most interesting because when people say to you as a parent, but my child never had anything bad happen to him or her. They never even saw a snake, or they never even had, trouble breathing. And the answer is, well, that's actually what, in this particular study, and that's been my experience too in my clinic, that less than half the time, there's a direct experience. And if you look, it's much more likely to be modeling or just hearing about things, information, instruction. And that's why, for example, when after like hurricanes or other disasters, it is true, and there has been studies showing that the bombardment of the media and the television can make some kids more anxious and nervous. And there is something to be said about limiting the amount of exposure to that type of information, especially if it's not going to be processed with the child. And that's really true. So, and I think this really highlights that. If you look at how many kids developed a lot of fear, mainly by information. But of course, the modeling plays a role too. Okay, everybody talks about cognitions, and when we talk about cognitions, we're usually making a distinction between thinking screwy versus not thinking. Like, are you just like thinking in a dysfunctional way, or are you thinking in a functional way, but it's distorted? Now, what does that mean? I had to think about that. This slide I actually got from Phil Kendall, and I had to think about this one. What do you think functional distortion? What do you think it means that you can have mistaken processing? I mean, dysfunctional distortion is clear. It means that if somebody is, doing their cell phone here, I then make a distortion of, they must be bored, I must be boring them, and that's a distortion. I mean, where's that coming from? But that would be a distorted, dysfunctional distortion rather than thinking they're rude and they're doing, I'm just making the point. But that's a distorted thing. If I right away make a distortion, okay. But what would be an example of a functional distortion?
If I don't study 6 hours on a Saturday, then I'm going to fail the test, which is just a false belief. There's no evidence for that, but it could motivate and help them be more functional in terms of outcome. Still a distortion. Or saying like...
But it's kind of dysfunctional, don't you think?
Only if it leads to impairment.
See, I think can I...
Yeah.
Yeah, I mean, it's a good, no, I don't really know the answer, and I was, but this is what I think, and I don't think it's really, I think with functional distortion, I think of it more with a depressed person, necessarily than an anxious, but maybe we can think of examples with anxious. So a depressed, with depression, it would be, let's face it, everybody, there's a lot of shitty things out there, right? Right? It's a lot of bad things happening. A lot of things suck. And I think functional distortion is, kind of like seeing things through rose-colored glasses and kind of like just not, I don't want to say denial, but it's sort of like, not seeing things the way they really are. And that's functional. Because if you really were to think about how bad certain things are, and that's like, say, women in abusive relationships, it's like, any of you know musical theater? Oliver? That song, As Long As He Needs Me. Remember Nancy is singing, Nancy is singing this to Bill Sykes, and the guy's like abusing her. And then she's singing, As Long As He Needs Me, I know where I should be. And meanwhile, the end is he kills her. Right. Okay? That's Oliver. That's Oliver. But, she was functionally, but she was distorted, So in some ways, it's because she was, so I kind of think now with anxiety, I don't know, does anybody think of a functional distortion with anxiety?
Well, there's things to be afraid of, that are real, but some people have difficulties because they're afraid of that. The likelihood of it occurring is very low, but they probably blow out of proportion that it could happen, the probability, the likelihood. The other way is they build up the consequence to something that's unreal. So I'm going to fail a test and it's going to end my life. It's not like, I mean, you could fail a test, but it's not going to end your life. The other way, I could catch a cold if I don't wash my hands every hour, but the likelihood of that happening is very low. So it'd just be two
maybe. I mean,
examples.
frankly, this is why it's not my slide. Because I actually find it a confusing slide. But I wanted to throw it up there because I really wanted more to make the point about distortions and deficiencies. Okay, and then I thought it would be interesting for you to think about that. But this is because this is why it's important for anxiety. Cognitive deficiencies are more related to externalizing behavior and limited distress. Internalizing are more associated with cognitive distortions. Okay, so that's why the distortion and deficiency distinction is important. You know, I don't know whether or not the functional and dysfunctional, that seems to be splitting hairs, but, and in fact, and again, Phil was very kind to share these with me. Look at this, anxiety, distortion 6, deficiency 0, depression, distortion 9, deficiency 0, ADHD, distortion 0, deficiency 9, aggression, it's similarly. So I think that's the reason why it's important, and when we get soon talking about the cognitive work, a lot of the work is emphasizing on identifying the distortions and what are the distortions as opposed to the deficiencies. It's not that they're not thinking about things. In fact, if anything, they're thinking too much about things. So that, as opposed to the, the ADHD child who's, not thinking about things. So that's a very important distinction in psychopathology. And, and that's the link between the cognition, the behavior, and the emotion, the deficiencies and the distortions. And what I just shared with you, that probably took some people 15 years of research to figure that out. I mean, to do all those studies. Yeah.
So then the cognitive distortion would maybe lead to the somatization examples if we're
Well, we're going to talk more about the distortions. Yeah. Yes, but the answer is yes.
I was wondering if the cognitive distortion is also cognitive rigidity, which there is like a continuum of that.
Yeah.
Because sometimes they may not even understand that other people don't think
Yes.
like that.
And we're going to get into some examples. But yes, that's right. Okay, so parents. So I want to make it very clear, if I wasn't clear yesterday in my presentation, parents do make a difference, and they have been found to maintain, to be involved in the development and maintenance. And these are the characteristics of the parenting skills. They tend to be over-controlling and more encouraging of avoidant behavior, or what we call overprotective. In fact, before I go further, that's my wonderful slide that I love. What are you doing? Researching trips to the South Pole. I'm thinking about visiting my pal, Allie the penguin. He's the one with the overprotective mom. But all those stupid penguins look alike. How would you even find him? I love that slide. So this is true. I mean, there have been, again, behavior observation studies where they have had children playing in playgrounds, and then they've done observations on the mothers. And you have some mothers sitting and looking at their magazines or talking on their cell phone or talking to their friends, but then you have the mothers, be careful, don't go up, hold tight, not any higher, you're gonna fall, be careful. And they have they've done that. You've seen, right? Anybody go to parks, you see it all the time. And so, and it's clear. And so what we're doing, and I'm going to talk, so what I'm doing in my current research study, I have 3 conditions. One condition is working alone with the child, individual. My second condition is working with the child, and we are teaching parents not to do this, okay? The third, because I'm trying to really understand parents. And the third condition is working on the relationship. So it's, you know, making them like each other and bond and improve the relationship. And that's my 3 conditions, because I'm really trying to understand the role of parents. And so, you know, and so that's what we're doing. In one, and you have the manual for the individual. I have another manual, and if you want it, as long as you don't put it on the New York Times bestseller, if you wanted, my other manual is individual, but training parents in how not to be so over-controlling and encouraging of, and not being so overprotective. And then my third manual is improving the relationship, you know, like, you know, scheduling fun activities together and, you know, say nice things to each other, identify things about the child that you like. You'd be surprised, you know, I mean, it's, you know, it's actually surprising when you hear how some of the, some of the lousy things parents say and think about their kids. I mean, I'm really actually surprised sometimes. And you know, I know. Maybe you're not surprised, but when I first got into this business, I was actually sort of surprised. And you know, and you definitely do see that, you know, like no matter what the kid is doing, the parent is always just seeing something bad about it and just can't see anything good about it, and just like saying, oh, but it was easy, oh, but that wasn't anything, and but you should see him other times, and you know, that kind of language. So that's our 3 conditions, because we're trying to understand, given that these are influences, does it make a difference if you change it, like I talked yesterday? So we're really experimentally manipulating that. You know, individual versus teaching parents individual plus this versus individual plus that. And, you know, and we're doing the mediators. So, and, you know, and then fathers, there's very, very little work, but the little work that's been done on fathers does show that the fathers of anxious kids tend to limit the risk-taking, and they also tend to be more unpredictable, punitive, and explosive. But again, there's very little work with fathers. Yeah. Yeah.
I was just curious about the cultural influences, because I think in some families that I work with, I mean, if the little boy is showing signs of sensitivity, that's not okay. And, you know, buck up and those kinds of things. How do you handle that?
It's a big issue, and especially with, with the Latino families. Many, I won't say many, but there's a good number of mothers who don't want their husbands to know that they're coming to us, because the fathers will be very upset and will think that they're against it, and it's like they just have to buck up. I mean, frankly, you know, you just have to, like a good therapist, you got to deal with these kind of issues. I mean, that gets into a whole another realm. I mean, but you need to be sensitive to that, and you need to work with that. You know, I mean, I don't know how else to answer that except to be sensitive to it, and you know, you can't really change that. You know. So it's an issue, though. I mean, I think education is always a good thing, you know, and explaining to parents that the child is suffering from an anxiety problem, and they're not doing it on purpose, and there are ways to try to learn not to be that way, and you know, try to frame it like that.
Yeah, I just wanted to say that, you know, there's a lot of good literature that would fall under treatment engagement strategies. And that's where I found the best ideas about engaging families from a cultural perspective.
Yeah, thank you. Yeah, Mary McKay.
Yeah, Mary McKay is excellent.
Is probably the leader
for
in the
Latino
field.
families.
MCKAY,
Yeah.
and she's a social worker in Columbia, and she's probably the leader in engagement strategies.
And Nancy Boyd Franklin for African American families.
Right. Yeah. That's right. They're excellent. I mean, although their main, I mean, we actually use their activities as well to try to keep them in the treatment, you know, because we want to keep them. We don't want them to drop out. And so they have a lot of the strategies. It's just like, you know, identifying the barriers, you know, like car service and scheduling and just kind of basic things like that. And then, you know, but then of course there are other psychological barriers that they talk about. So, yeah, thanks. Okay, and now I'm putting this up because this is where NIH is going. And so I would not, I would be, and so I'm not going to get into this because I'm not an expert on this, but NIH is really, really, like they're really now all about neural circuitry. That's all the buzz, that's all they want, and it's actually, for people, a lot of the psychologists, I think, are feeling a little nervous about it because we feel there's still so much to know about psychosocial, psychological events, and I think some people feel that they're kind of like throwing out the baby with the whatever it is, the bath water, yeah, and they're kind of like taking a whole new path, and they really feel like this is like going to be the answer to everything. I was watching the Today Show getting ready this morning, and they had a thing on the Today Show about the brain, and it's all about the brain, and everything's about the brain. So this is where it's at. And I can't tell you I understand it so well, but this guy, Danny Pine, who's actually at NIMH and is a really nice, wonderful guy. I like him a lot. And he's an anxiety researcher. And this is from an article he published. And basically he's talking about this, and then you got brain circuits and environmental, and then these are, PFC, the prefrontal cortex. I mean, so you got these, different circuits in the brain, which you then need to then understand how they relate to psychological processes. Which of these things in the brain, how do they affect memory, response inhibition, and then how do they then lead to or predict these types of disorders. So I mean, that's, probably like a preschool explanation of it. But that's, but that's a really nice, that's the best I did. When I try to get some summary of it, I couldn't give you words because I wouldn't be able to, but I think the figure explains it, gives you a nice overview. Let me get this thing for you. Okay. Now watch, this guy's going to have a Ph.D. in neuroscience. What? You're Silverman, you might. Oh, okay.
I guess my problem with that is that, from my point of view, the arrows can go in the other direction as well.
Thank
they're
you.
dual arrows because...
Thank you.
And I think there's a tendency with this to see it that because there's a correlate of brain patterns to a certain behavior, therefore if you change the brain's pattern, you'll change the behavior, but it works the other way around.
Totally, 100%. I agree with you. My analogy is I mean, if some of you were trained as psychologists and never learned the Rorschach, this reminds me of that. It's like, let's give the Rorschach and let's see what the ink blot looks like, and this is going to be predictive of some groups, and it never worked. They never were able to find that. It was never a diagnostic tool how you did that. Now it's like, okay, so it's not the Rorschach, now it's the brain, and let's see if there's some circuit. Okay. So that's the etiology. But again, I think there's a role for everything. My only objection is that I think we need to be open to all possibilities of how things develop, and I would hate to see the field moving totally against psychosocial and totally towards neuroscience. I think everything has to be integrated. I mean, that's my conclusion.